Hello everyone. Most of us must have seen a patient who are diagnosed with hypothyroidism and taking their thyroxine on a regular basis. Still, TSH is high, hypothyroidism is not under control. In this video, we'll discuss these issues and try to solve those problem areas which can lead to high TSH or uncontrolled hypothyroidism. Let's start with this case. So, a patient, middle-aged female, she came with hypothyroidism diagnosis, and that was for 20 years, last 20 years, and she is taking 200 microgram of the thyroxine replacement, and her TSH is usually under control. So if you can see the date of presentation, 2022 patient come to us in the OPD, and the dose was 2 tablet of 100 mcg of thyroxine. She was taking that particular dose, and she was regular with the doses. This was the test report. She was not so regular with the follow-up. Usually once a year she used to come and get the test done. So on 20th of March 2023, so you can see here 2023 the report of TSH was 2.31. So that means ki it is controlled. It is controlled. So we continue with the same dose of the thyroxine here. But when patient came recently, January 2025, TSH was 99.6. So TSH went up to such a huge extent. So we try to identify what could be the reason for this high TSH. First thing that we asked is, of course, the compliance with the medication, whether the patient is taking the medicine regularly. So this is the first step that we should ask from the patient. So non-adherence or non-compliance can be because of just forgetfulness, or it can be because of intentional non-adherence. Like you must have seen some patient say कि डॉक्टर साहब मैं जो है वो मेडिसिन खाते खाते तंग आ गया, so I have left the medication. So that is one of the common thing which is told by the patient, intentional non-adherence. This is the problem area. So what is the solution? Simplify the dosing of the patient, and we will provide the reminder to the patient, maybe through WhatsApp or maybe through some caregiver. We will tell them ki reminder should be there in the phone, daily alarm will be there in the phone, so to prevent the non adherence. That will help. But when we ask the patient ki whether she was taking the medicine, she said yes, she is taking regularly. So this is not the problem area of our patient. Second important problem area can be change in the weight gain, because the dose of the thyroxine is dependent on the weight. More the weight, more will be the requirement. And this issue, the solution is weight reduction with diet and physical activity. When we check the when we check the weight of the patient, so weight was constant. So that was also not the condition. Third cause of increased thyroid requirement or thyroxine requirement is the malabsorption of the thyroxine. So malabsorption of the thyroxine can be because of some gastrointestinal disorders like celiac disease, which is gluten allergy, or can be Crohn's disease. Can be medications like proton pump inhibitors. They decrease the acidity, and this thyroxine is absorbed from the duodenum, where acidic environment is needed for its better absorption. Calcium carbonate iron supplements bind with the iron and decrease the thyroxine absorption. So we will ask specifically the timing of those medication from the patient, especially the iron supplement and the calcium supplements, because they are very commonly taken by the patients with hypothyroidism. And of course, some weight loss surgeries do reduce the thyroxine absorption. So what is the solution? We will assess for these symptoms. We will try to treat Crohn's disease and give gluten-free diet in celiac patients. And we will assess the medication of the patient, and we should change the timing of the medication. How? Like we should ask the patient to give a gap of at least 5-6 hours between the calcium and iron supplement and the thyroxine dose. So that will be taken in lunch or during the dinner time if patient is taking these iron or calcium. But patient was not taking iron or calcium, and patient was on multivitamin, but that was at the lunch time specifically told to the patient. Other issue can be the wrong timing of the thyroxine, because the thyroxine is taken in the empty stomach, and 30 to 60 minutes before the food it should be taken. So if the patient is taking with the food, or immediately 5 to 10 minutes after patient is taking tea or coffee or milk, then the absorption will be less. So this could be due to just forgetfulness, or maybe some job related things, like patient has night shifts, patient is not able to follow the prescription of empty stomach taking the thyroxine. What exactly is the solution for it? Always in each visit, ask the patient ki whether patient is taking it on empty stomach with a little bit of sip of water, and giving a gap of 30 to 60 minutes before taking the food. Always, every visit you should ask this question. And if the timing is an issue, then you can consider alternative timing. So it has been seen, if it is taken 4 to 5 hours after dinner, say in a patient having night shift, then it can be equally effective bedtime administration of thyroxine. But those were not the problem area with the patient. And pregnancy, that is specifically to the reproductive age group, because in the pregnancy what happens, that there is a increased demand for the thyroid hormone. Reason being, in pregnancy estrogen increase, thyroid binding globulin increase, and that bind the T4. And if the T4 is bounded with TBG, free T4 will be less, and hence the requirement will be more for the thyroid hormone. As well as from the placenta, there is one enzyme which is released, deiodinase D3. That enzyme causes the conversion of T4 into reverse T3, and reverse T3 is inactive form. So you should be aware of the metabolism of T4. T4 convert into T3 as well as reverse T3. T4 converting into T3 active form is by D2 variant of enzyme deiodinase. So that is needed, active form of T3. But there is a D3 deiodinase also that convert T4 into reverse T3, which is inactive form. So remember this point, D3 and D2 deiodinase. D2 is a normal conversion to T3 active form. D3 deiodinase is converting T4 into reverse T3. So reverse T3 will cause a problem. Solution: adjust the thyroxine dose, and frequent TSH monitoring will be done if pregnancy is there. But patient family is complete, so there is no as such pregnancy diagnosis in our patient. Other issues can be drug interactions. So some drugs by increasing the thyroid clearance increase the metabolism, or catalyze the thyroxine, will increase the requirement, like estrogen containing therapy. Anticonvulsant drugs like anti-epileptic drugs, phenytoin, or rifampicin, ATT, a liver enzyme inducer. So they will cause more thyroid clearance, increase the requirement of thyroxine. Solution: review the medication list, ask the patient whether patient has started with any anti-epileptic medication, or is taking oral contraceptive, or is taking ATT, rifampicin. So accordingly you can adjust the thyroid dose, because we can't stop rifampicin in ATT, so we have to increase the dose of thyroxine. Similarly, if patient is on anti-epileptic medication, we can't stop those drugs, we have to increase the thyroxine. Now this thing, autoimmune flare, especially in a patient with hashimoto-thyroiditis, antibody can become more active, and they cause fluctuation in the thyroid hormone requirement. So this is a very important issue, especially in the Hashimoto, ki patient is taking medicines on a regular basis, same doses, and suddenly the TSH shoot up. This is a phenomena known as autoimmune flare. Antibody become more active, that is destroying the gland more, so requirement will be more. And how to solve this issue? If patient can afford, get the anti-TPO done. If the levels are rising, then adjust the dose accordingly. But if patient is not able to afford, because TPO antibody is a costly test, then we can increase the dose, assuming that it could be a Hashimoto's flare up, after excluding other reasons for high TSH. Lab error can be there. So lab error can be present because of the processing, sample collection. So the solution is, ask the patient to repeat the TSH from a different lab, so that will confirm before taking a decision. This is a very important advice. Before taking a decision of increasing the dose, if you have any doubt about the lab, recheck the test TSH from a different lab. Stress and illness. Yes, this is a very important issue. In stress, cortisol level increase, cytokines can increase, same with any illness. So those cytokines, they alter the thyroid hormone metabolism. How they alter the thyroid hormone metabolism? High cortisol and cytokine increases the D3 activity, which we have discussed earlier. D3 deiodinase convert T4 into reverse T3. Reverse T3 is in active form. So therefore the requirement of the thyroxine will increase. Solution: treat the infection, stress management, keep the dose same, because it is a temporary phenomena. Do not increase the dose during the stress and during the infection. Keep the thyroxine dose same, repeat the thyroxine after 6 weeks. This was the case which came to us. 51-year-old female, she is taking 62.5 mcg of thyroxine for the 5 years. She was regular follow up with a stable TSS. So you can see the investigation date, 2023 TSH 0.477, December 23 0.38, May 24 0.080, August 24 TSH 4.06. So fairly constant. We kept the dose as the same. So when the patient visited in August, the dose was 62.5. Now when patient came in November 2024, see the date, the TSH value shot up to 8. So this was the value. So on the detailed history, we took the history taking is very important. So there was a stress. The reason for the stress, because her son was having issue in settling in the college hostel. So this is a problem with the parents these days. So that was the stress. And after that patient came to us in November. So the dose was 62.5. We kept the dose as the same. Indeed, patient was happy that we are keeping the dose same. We are not increasing the dose after seeing a TSH of 8. So the dose was same, 62.5 in November. We asked to get the test done after 6 to 8 weeks. Now let's see the result. 21st of November, result was 8, and 29th of January this year, result is 2.5, with the same dose, but it was with a better stress management. The TSH came out to be normal without increasing the dose of thyroxine. So you can see the date, 1st of February patient came, and the dose was same, 62.5. That was the same dose which we kept. Nutritional deficiency, though rare cause in urban population, so selenium and zinc, they are needed for T4 to T3 conversion. So if there is a deficiency, there can be issue with the thyroid management. Solution: check free T3 levels, and if the free T3 levels are low, T4 is okay, T3 level is low, then we can think of the zinc and selenium deficiency. Clinically check. Zinc deficiency causes delayed wound healing. Ask that from the patient history. Selenium cause muscle weakness. Ask that from the patient. So if patient can afford that, those tests can be done. If patient is not affording those tests, just clinical basis, check the free T3 levels. If it is low, then suspect zinc and selenium deficiency. Then correct those deficiency, maybe with supplement or with diet. Like zinc, it is present in pumpkin seeds, and selenium is maximum concentration in Brazil nut, so that can be given to the patient. Goitrogenic foods, so this is one of the important area, goitrogenic foods, but recent studies says ki that it does not have such huge impact on the thyroid if patient is taking thyroid medication on a regular basis. So these are the common food items by inhibiting the iodine uptake or inhibiting the thyroid peroxidase activity. Thyroid peroxidase is important for thyroid hormone synthesis. Or soy based foods which decreases the thyroxine absorption. What is the solution? Solution is, ask the patient to consume these foods in moderation. What is the meaning of moderation? Like once or twice in a week patient can have cauliflower, cabbage, like that. And mainly cooked food. The problem occur with the raw food. Avoid consuming the soy based proteins, and within 3 to 4 hours of taking the thyroxine, to so that interference with the absorption of thyroxine will not be there. So these instruction we should give to the patient. Now in the summary, what are the causes why TSH is increasing despite regular dose of the medication? Number one is non-adherence, weight gain, malabsorption syndrome from the GIT, wrong timings, pregnancy, drug interactions, autoimmune flare of Hashimoto's, lab error, stress or infection, nutritional deficiency, or goitrogenic foods. And in the first clinical scenario, the most likely cause of high TSH was autoimmune flare. And when there is an autoimmune flare, we have to increase the dose of thyroxine depending on the thyroid level. So this is the discussion ki how to check for high TSH, what can be the problem areas and how to solve those problem areas. If you want to share your experiences or you want to ask some questions, you can put in the comment section. Thank you.